I agreed. Just kidding. So this case involves a young woman, and let's see if I can make this work. Specifically, this couple of facts that may become relevant later on. I just want to let people know this was the first week of August, and I'll let you know what happened last week, which is a good thing, but keep in mind this all started in August. The patient was a healthy 16-year-old female who was involved in a motor vehicle accident approximately 5 days prior to our case. She had fractured her ankle and required an ORIF of that ankle. She also happened to be 28 weeks pregnant. This was scheduled as the second case of the day in room number 3. Now, if you remember, this orthotrauma goes back and forth between 2 rooms. So, we know we're going to have a hiatus to get things kind of straightened away before we start this case, because she's staggering between 2 rooms. I get a call the night before to let me know about this case, and it was a phone call from a CA1 resident, and we discussed the case, and our first choice, being as she was pregnant with a viable baby, that we would do a spinal with Precedex sedation. Any other considerations or questions at this point? Otherwise, I'll just go right on ahead. In the morning, I sought out Jason Papazian just to run the case by him to make sure I was thinking about it the right way, and he thought he liked our plan, and said he was available to help. The other thing that we had discussed the night before was that we would have acute pain, see the patient and put a block in. So she would have post-op analgesia. Of note, at about 6 o'clock in the morning, when the patient checked in to pre-op, the pre-op nurse goes, "Oh, this patient is pregnant, and she says she's 28 weeks." And she initiates at that time what I'm going to call the pregnancy protocol. And that involves calling OB, the labor and delivery, letting MFM know that there is a pregnant patient with a viable fetus in the OR. They need to schedule intra-op monitoring, and they have to let NICU know something might happen, and our OB attending gets a notification because they may be called into action as well. In fact, I got a phone call from Brenda Buckland, who was the OB attending that morning, to discuss the plan and to indicate that she was available. She was on board with our plan. In fact, been doing this for more than 1 decade, and I've had several pregnant patients in the OR, done dozens of them, never had a problem. So yes, we activate, but rarely do we actually have a problem. This is actually something I want to talk about later on, about how this patient got to pre-op the morning of without anybody knowing that she was pregnant. Yes? Just to give you an idea of how kind of deep this stuff gets. Now, you know, I mentioned the MFM attending knows about this, and it's more than just knowing that, hey, we've got somebody downstairs we may have to do something about. They actually come down and do a couple of things with the patient that morning. One of them is just to say, hey, you're at 24, they initiate this at 24 weeks. So at 24, 28 weeks, one of the questions is, something goes wrong, do you want us to deliver this baby? So I didn't know they consented in that way, but they do. Another thing is, well, this is a 28-week infant or a fetus. Should we put them on methyl or beclomethasone? Sorry, it's a tongue twister for me. But to mature the lungs. And the patient did, in fact, say, yes, I want this baby taken care of, and yes, go ahead, give me some beclomethasone. And in fact, if this had been, this patient was known 5 days before, if you remember, that she was going to be coming to the OR, MFM would like those consults to be notified at that time so they could give the beclomethasone plenty of time ahead so that the lungs are as mature as they can be and have at delivery. So this patient only got 1 dose. So that's one of the things that does happen when this is initiated. And there's been a lot of discussion about how did this patient slip through the cracks and how can we prevent that in the future. But still, thanks to that pre-op nurse, everything got done that morning. Everybody was notified. So we're going to show the anesthesia record here. You can see it was the second case. You can also see that our pain team put a block in for post-op pain. So we get the patient in a little after 8:30 in the morning. We put our leads on, and we start with the spinal. So at about 8:57, we get the spinal in, and we begin to reposition the patient to supine with a right hip bump. And about the time she lays down, I mentioned to the residents, good time to start the Precedex. So that was at 9:01. And we were going to load at MIG per kilo or mic per kilo over 20 minutes. Then we were going to turn it down to 0.2 mics per kilo per hour for the duration of the case. At about 9:02, after she lays down, as a habit of mine, I asked the patient about potential nausea, because that's usually one of the first things you see after you put a spinal in. And it lets you know that the spinal setting up, you might need some phenylephrine. And on cue, she attempts to vomit on my shoe. And so I looked up, the blood pressure had indeed fallen to about 90/45, and I gave a dose of phenylephrine. A few minutes later, the OB nurse who had come down from labor and delivery, who was doing the monitoring, said, hey, the fetal heart tones have dropped from like 160 down to about 100 beats per minute. And she said, what's the blood pressure? And I'm thinking, well, you know, it was just low. I'll see what it is. I look up, it's 185/100. And I also note that she's starting to get a little weird. Doesn't look like a normally sedated patient. And also that the heart rate is decreasing. And here you can see up here that the blood pressure after that initial dip spikes way up and the heart rate drops precipitously. Oop, I hit the wrong button. Let's see. At about 9:07, the sensorium's not right, the blood pressure's not right. I don't know what's going on. As I said, I've done this dozens of times over the years. I've never seen anything like this. I said, let's start removing variables. let's stop the Precedex. So at 9:07, even though it was only about 6 or 7 minutes into the bolus that she was supposed to get over 20 minutes, we stopped it. I also put a call in to Jason Papazian, who was kind enough to say, hey, I'm just down the hall. If you have any problems, call me. I said, Jason, can you come into room 3? So Jason walks into room 3, and at about the same time I'm calling Jason, the OB nurse who's doing the monitoring has put out the alert that she wants the MFM team and the NICU team in the OR as well. And to put things mildly, the room fills up. The room's already full because it's an ORIF. We have 3 OR tables, 2 of them with equipment for the ORIF, and there's a C-arm in there. So it's already pretty full. And then, Jason, how many people would you say were in there? 25? 30? Okay. It seemed like a lot. And you can, here's the rest of the case. And I'll mention that at 9, approximately, I think this is pretty exact actually, but at exactly 10 minutes after the note of the decreased heart tones, the nurse keeps a minute-by-minute count of how many minutes had they been decreased or absent. One of the things that happened during this period of time is she lost them, and that, I guess, frequently happens when you can't find them with their instrument that they use for counting the heartbeat. So they asked for ultrasound, but there was no ultrasound. So as far as we knew, it could be there were no heart tones or they were absent. In any case, at exactly 10 minutes, they say, okay, it's time for a C-section. The MFM attending is in there and says that. And 1 minute later, the baby, the premature infant, is out and handed off to the NICU team. And I can't tell much, but from my eyeballing, the baby looked okay. The heart tones were good, baby was breathing, looked alive, things were okay, it was pink. So I was pretty relieved at that point. Any questions? So now we've had somebody come in, 16 years old, 28 weeks, has now had a C-section, and we have a premature infant. We've also had about 30 people in the OR, and Dr. Gorman says, you know, I don't think any of my instruments are clean enough to put in somebody, even though we have a fine anesthetic going here, we're going to cancel the case. Yeah. Oh, yeah. Sorry. Yeah, right here. So yeah, right in front of the actual seat. So the baby, or the patient was set for a C-section prior to 9:15. So we were already ready for a C-section. We were just waiting for them to call. Part of it was this strange sensorium the patient was experiencing, and we just wanted to get control of the situation. Yeah. No. No. Yes, we'll get to that in a second. But that's a very good question. What was the spinal dose? Spinal dose was on the low side. This was a small patient, about 50 kilos, maybe a little bit less. She was short. We had a block in for the leg, so it was a CC of marking. So it was on the small dose side of things. That was a question when Jason entered the scene. He was thinking that her sensorium was due to a rising high spinal. So we were ruling that out as well. I was skeptical that it could be a high spinal, but because of the dose, but that's a good question and should be evaluated, and it was. A couple other things were happening fast, but a couple things that jumped out at me was that one was the OB nurse and then the MFM attending said, hey, this uterus seems to be clamped down, which seemed a little bit strange. And this is a note, and why we try to schedule these with OB attendings and residents who've had OB is the first thing Jason did when he came in the room is he grabbed the resident, looked him in the eye, and said, go to the pharmacy and get an OB box with all of the tocolytic agents. Things to relax the uterus and things after the C-section, if there's a C-section, that we can squeeze it back down. I didn't do that. Should have been done. So that's, but that happened also in this period of time prior to 9/15. So we had all of those drugs available. There was concern that the uterus was tight, and that may have been the reason for the fetal heart tones being low, but we didn't know at that point. So things settled down. The next day, I went with the resident to see the patient, discussed briefly about the infusion of Precedex. Was it really Precedex, et cetera? And we had already determined it was, and that a large dose had been given. And then how did this happen? And it occurred to me at that moment that, hey, wait a minute, where's that pump? There was something wrong with the pump. So I went back to the room. It looked like the same pump. I was pretty sure it hadn't been removed. Pulled it out of the room, called biomedical engineering, and then called the Alaris people in-house to have that pump interrogated. And this is almost a readout from what they had interrogated from the pump. And you can see that it was initially programmed as a basic infusion back at about 8:18 at a rate of 75. So the amount to be infused was way high. It should have been about 12 and a half by my calculation, and 12 and a half mils because it's 4 mics per kilo, or per mil. And so what I'm thinking is it was mistakenly, where's my, it was probably thought to be at, that it was only 1 per cc, because that's about 4 times too high. Then a few minutes later, it was programmed to a much higher rate, turned on, turned off, and then reset at another basic infusion at a rate of 282, and then put on pause to wait for the case to start. If you remember, I said about 9:01 is when we said start it. So it was started at that rate, and about 7 minutes later, I said turn it off. At that point, the patient had received 33 ml, which is about 132 mics, which is almost double what we would give in the whole first hour. And it had gone in over 7 minutes. This is the alarm that went off when Jason and I were discussing that this might be a Precedex effect. Jason took a look at the pump, saw the syringe plunger way down, pulled it out, and set off the alarm. So that was actually after the baby was delivered, and then the pump was turned off. The same pump was again used during that same case to give the propofol with the usual guardrails and typical infusion rates. And this, so just to drive home that when an event like this occurs, you should pull that pump out of service, make sure it's working properly, and find out a little bit about the programming error that might have led to this so that we can work on preventing it in the future. But that gets to the question, was this really Precedex? And yes, it was, but the infusion rate was not as intended. Any questions about this? I'll just mention, we'll probably discuss this at some length, but there are standard guardrails and programming language for Precedex or dexmedetomidine. So there's really no need to use the basic infusion rate for that drug. Does everybody understand what basic infusion rate means? That just means you can say it's a generic fluid that you're going to infuse at a particular rate. I want to go back here. So, a few comments about dexmedetomidine pharmacology. As you all know, it's a highly selective alpha-2 agonist. It activates, its mechanism of action is activating alpha-2 receptors in the brain at the locus coeruleus to give the sedation. Should be noted that overactivation of the peripheral, we have peripheral alpha-2 receptors, and if they're overactivated either because of patient inclination or because the dose was large, you can get unexpected hypertension and bradycardia, which is exactly what we saw. If you remember from the record, we saw really high blood pressures for a 16-year-old and bradycardia that was pretty profound. This can lead to a rebound autonomic hypotension and tachycardia, which we did not see, but you should be aware that that could happen. Both dexmedetomidine and xenon are considered effective anesthetic adjuvants. Xenon we don't have the capability of giving at our institution, or almost anywhere, but they appear to be less neurotoxic than other existing agents and have the potential of being neuroprotective in neonatal settings. So that's one of the reasons that we chose that as the sedative rather than, say, propofol or midazolam. There is very scant evidence of this, but I wanted to bring this up because it seems a bit relevant to us, in that there is human in vitro evidence, isolated myometrium, in which dexmedetomidine can cause increases contractility at what would be considered within the range of clinical concentrations. Now you have to remember, in these water baths, they don't really know what clinical concentrations are because you don't know what's actually in the uterus is seeing, but if you usually they're looking at things on orders of magnitude, and it's in the order of magnitude of clinical concentration. And the effects were also seen with clonidine, but at higher tissue bath concentrations, 100 times higher, indicating that this may be specific for alpha-2 because, as you remember, clonidine is a mixed alpha-1, alpha-2. Yeah. Yes.
So we theorize that this might be after the other thing that might actually be going on is her blood pressure spike. And this was so acute that she may have been disrupted. She may have had acute there's no real way. The reality is that children during surpluses that are earlier pregnancy, I do precedent at normal pressure concentration for the others. And Christine would, all of us do similar
Okay. I'll hand it over to Gina, but I just wanted to close that both mother and baby are fine. The baby was finally discharged home, healthy looking and growing last week. So 2 months in NICU.
So a couple of things that I wanted to mention, and the first was when we reviewed this case, to point out the positives, the depth of experts available within that room within minutes was incredible. The number of years of clinical experience, the 3 out nurses were on it, and activated the pregnancy protocol. I think all of that is to be congratulated, but it's all undermined by a comp program here. I will say that, if you haven't this program at comp, you had a program at oncology, so it will happen. The guardrails system in Alaris, so there's a broad category called drug care. And guardrail is just Alaris as the name for it, but that's sort of become the name for across most people that you talk about guardrail. But those are in place for a reason, and when we bypass those, we create a real problem for ourselves from a risk standpoint because we, as it's been explained to us by risk, we're willfully bypassing the safety mechanism that would stop the incident. The other thing is every keystroke that you push on an Alaris pump is treatable and potentially discoverable. And it would be very difficult to defend in court. The other thing is you're bypassing safety mechanisms that, theoretically are there to protect the patient. If there's problems with the drug library and the drug concentration that you need is not in there, that's a great QI submission and we'll take care of it. The drug library is continuously updated by the pharmacist. And so we can take care of that and get the drugs you need in the library and usable, within the dose range. OR is a little bit challenging because we use such much wider ranges of drugs than are commonly used throughout the rest of the institution. There is an anesthesia mode that, in which you have some more latitude for programming. But I just wanted to point this out because we've seen this come across again and again and again. None with effects as severe, but we have seen this theme. It's just a matter of time where we're not so lucky. Were there any other questions or comments? I know it's a few more button pushes to get out of that basic confusion mode, but I think it's time well spent.
Why is the program of basic?
I don't know. That was a choice of the anesthesia provider. The other thing is, I'll tell you, so at Children's we actually use more commonly used in pumps. We actually don't have guardrails on our current pumps. And so
Can't hear you.
We recently had a series of events at Children's as well. Dr. Sullivan's comment was, we routinely simulate rare events like MAs you may never see. These events happen commonly where the drip's not hooked up or a stopcock's not turned and the patient's not actually receiving medication. So I will tell you we've had a smattering of similar events, and we've actually instituted as part of our cardiac hygiene handoff. We actually physically run the lines of the receiving nurse because in children in particular, nitrite is relatively concentrated relative to the dose of a very low rate. And there's a pressure buildup behind the stopcock that's not turning. You can have cardiac arrest when you turn that stopcock. You don't know that you can press that line. So we have had a series of similar events. It's not unique to you.
For new trainees that have not had exposure to operating their do they get formal training on that so they get into the operating room?
Well, I guess they can. We're in the process of actually setting up training sessions. They'll be in the place breaker. So it's funny having conversations with Gabby, who's trained sort of more through the nursing pathway. And she said, well, how did you learn to use an infusion pump? Like, you just start using it, right? And it's a very different way of thinking. But, even knowing why guardrails are in place is obviously important. Go ahead.
Was NICO considered in this case with the possible advocacy and consequences? Weird. I would prefer that you would great.
And then Dr. Mary Berg from Blood Bank is here to talk a little bit about infusion medicine and things that they're seeing.
Can't hear you.
It's on? Okay, now that's on. I got it.
Thank you.
All right. So, yeah, I'm Mary Berg. I'm medical director of the blood bank, also sometimes referred to as the chief vampire or the chief of the platelet police. So I think I'm kind of here as your comic relief today, but we're going to talk about three quick things in the blood bank. One is product wastage, what fluids are acceptable to add to blood, and what's up with the whole antibody thing, if you know your patient has an antibody. Okay, first of all, blood wastage. In general, this is how much we waste per month at University of Colorado Hospital. This is only for UCH. So you can see that it varies quite a bit, but usually somewhere between $5,000 and $10,000 a month. Just to break that down a little bit so that you can see what this looks like. And let me use this. So you can see that down here, plasma, red cells, platelets, cryo. This is for April, May, June. These are our most recent statistics. We do our reports on a quarterly basis. We don't have the last quarter done yet. But one thing that you can notice is, for example, you can waste a lot of plasma, and it's not necessarily that expensive. You waste a few platelets, and it's very expensive. So platelets cost about 8 times as much as a unit of plasma, and that's why if you waste 1 unit, you're wasting a lot. And to me, our total cost or our total percentage over here being around 1% of our budget, that might not seem too bad. But one thing I always emphasize is that if you tell a blood donor that we just threw your blood in the trash, they might not want to give anymore. So for us, any kind of wastage is kind of an obnoxious thing to do, so we really don't want to do it. And anything you guys can do to help us not do that would really be appreciated. In terms of what causes the waste, some of these things we really can't do much about. Again, I have to use this. That what I would really have you focus on are these things that are the ordered, not given things. So you can see that some of these things, like in this case, we had somebody must have dropped a box of plasma when it was frozen, and then when we started to thaw it broke in the thaw, or it started leaking in the thaw. So things like that, where the actual bag breaks, is not something that we can necessarily do anything about. But if we set something up because somebody says, oh, we need it, we're going to transfuse it, and then they don't use it, we can only do that just so much, and then after a while, that's going to go to waste. So as an example of that, this is looking at the total of number of units that we issue every month. That's the lighter line. And then the darker line is the total number of units that get returned to us. And we do this in general just to show that it's around, say, between 25 and 30% of our units get returned to us. And back before we updated to a modern computer system, we could actually break down by service as to how this was happening. And if you take a look at this, this is the percent of units returned. This is actually back from 2015, before we changed to our new computer system, because with our new system, we can't tell anymore. But what sticks out? The biggest place where blood is wasted because it gets ordered and not used is in the operating room. So we would really appreciate it if when you order blood, you think twice about, are you really going to use it, and how much do you actually need? It makes a difference if you order 8 units and you only use 2, because then we have extra units that have been taken from the blood bank and we can't use. So please think about that when you're doing your ordering, and not over order or send back as soon as you possibly can when you're like, okay, we definitely don't need this. Send it back so that we don't waste it. Okay, in terms of acceptable fluids, this has come up recently because we've had a few cases where something is infused with blood when it's not supposed to be. And I could give you the Code of Federal Regulations, but that's a little hard to follow in terms of their logic. So I'm just giving you the AABB standards. We're an AABB accredited organization, and so we need to follow their standards. And this pretty much follows what the FDA regulation tells us we have to do. So basically it says that you can't use anything other than sodium chloride unless there are certain criteria that are met. Number one, it's been approved for that use by the FDA. And number two, there's documentation to show that it's safe and that it's not going to adversely affect the blood component. So for example, if you do an in-house validation of a particular type of fluid that you want to use with blood and you say that it's safe, or you find something in the literature to say that it's safe, then it's okay to use that. But if you're going to do that, we would really appreciate it if you would send that information to the blood bank, because the FDA is going to be coming and asking us why we let this happen, when of course we don't let this happen. We have no idea what kind of fluids you're using in the operating room. And just to point out what the regulations say and what science tells us don't necessarily agree. This is a recent article from a journal that talks about normal saline, and perhaps it's not that great to add this to the blood. And this is just the abstract from the article, but the highlights of this is basically that normal saline is the only solution recommended for red cell washing, administration, and salvage in the U.S. Plasma-Lyte A is also FDA approved. So in terms of that first criterion from the AABB standard, what's FDA approved, it's normal saline and it's Plasma-Lyte. And although traditionally we've said lactated ringers is not acceptable, that's because of the higher calcium concentration that's going to overcome the citrate in the unit that was used for anticoagulation. That might not actually be a problem, but unless we either have literature to support that or have an in-house validation to say that it's safe, we're not supposed to use that. So in general, what the authors of this article were saying is that Plasma-Lyte A is probably a better thing to use than normal saline, but of course it's a little more expensive, and that's why people don't want to use it. But just to point out that there is literature out there about what's safe to use with blood, and if you're going to use something other than Plasma-Lyte A or normal saline, then be sure that you have documentation to show that that's effective and safe for the blood. Anything else is really not considered acceptable. Okay. And then quickly, a little something about antibodies. You've probably had a situation where you were doing a pre-op assessment, or maybe you had the patient in the operating room already, and you find out that the patient has an antibody. And you're like, oh, okay, how important is that? Well, first of all, let me just tell you that we set up a system specifically to try to avoid the instance where you're in the operating room when you find out the patient has an antibody. Whenever you do your pre-op assessment for 30 days up to prior to the start of surgery, you can order a pre-op type and screen or even a type and cross-match if the patient doesn't have antibodies. The rule for this, and this is a federal regulation, is the patient can't have a recent pregnancy or a recent cellular transfusion. That means red cells or platelets, and that's within the previous 3 months. And there's a way of signing off on that in the computer to say, I know this patient has not been previously pregnant or not had a recent transfusion, and then this specimen is going to be good for 30 days. So if you have had, the patient has had a recent transfusion or is currently pregnant or recently pregnant, there's going to be a 3-day limit. And again, that's a federal regulation. It's not something that we can work around. But if they don't currently have any antibodies showing or they don't have a history of antibodies, then they'd be eligible for an electronic cross-match. So the rules for electronic cross-match are that you have to have 2 types on the donor unit, which we always have because we get a type based on the blood center does the typing when they label the unit before they give it to us. And whenever we receive a red cell unit in inventory, we always confirm the type. So before we can use it, again, federal regulation, we have to confirm it. So if to say it's labeled as an O-pos unit, we have to confirm that it's O. If it's labeled as O-neg, we have to confirm that it's O and that it's Rh negative. If it's Rh positive and if it's truly Rh negative and labeled as Rh positive, nobody's going to care. That's not going to cause a big problem. So we have 2 types on the unit, and we have to have 2 types on the recipient. So that's why we're always nagging people to get a donor retype or a patient retype, because if we get that, then we can do electronic cross-match. And that means we have a computer now that, this is one of the benefits of the upgrade, that it has the logic in it that it will not allow us to issue a unit that would be incompatible with the patient. So if your computer has the logic to say, oh, this patient is A-neg, and you want to issue this unit that's labeled as A-neg, that should be safe. And it will let you do that. You don't have to do a serologic cross-match. So that means that basically we take the type-specific units off of the shelf, do the stuff in the computer, and we can issue it. It's a lot faster than doing a serologic cross-match. And obviously, if you need blood quickly, that's a definite benefit for the patient. So if the patient is currently pregnant or has recently been pregnant or has recently been transfused, they can't have a 30-day pre-op specimen, but they can get electronic cross-match, assuming we have 2 types on them. One of them can be a historical type from even 10 years ago, but we need to have 2 types on record for them before we can do that. If, unfortunately, they do have a current antibody or they have a history of antibodies in our system, then we have to keep our records of antibodies indefinitely, according to federal regulations, then we have a 7-day limit on how long we can actually use that specimen. So you could still do your 30-day pre-op workup, and then if we say, oh, this patient has an anti-Duffy A antibody, then, I don't know, the day before surgery, a week before surgery, have them come back and give us another specimen that we'll then be able to use for cross-matching on the day of surgery, okay? They're not eligible for an electronic cross-match, and if they have an antibody that's currently showing, well, even if they have a history of a significant antibody, then it's going to take at least an hour to do the cross-match because it includes a 45-minute incubation. So we're not going to be able to get you the blood quickly if they have an antibody. But then it's kind of a question of how do I know my patient has an antibody? So for anybody who hasn't seen this, hopefully you recognize that this is something from Epic, that up in the allergies tab, they'll list that there's a red cell antibody, okay? And this is something, this is not automatically done by Epic. This is something that the blood bank techs do when they identify an antibody. They make sure that it's listed in the allergies tab. They go in and they manually do this entry. So if you were to click on this, then you would see what type of an antibody that they have. And it gives you some comments. Then you might want to take a look actually at the results tab so that you click on this, you say, okay, these are all my blood bank results, these are units that we've received. Oh, look over here, this is something that says there's an antibody, and especially if it says MD and TERP, that means that we've put in a report, one of the medical directors of the blood bank have put in a report about this antibody. So in this case, this was a really funky antibody. It was an anti-Duffy X, which makes you incompatible with just about everybody on the face of the earth. And so we give you a lot of additional information about how bad this antibody is and how hard it is to find compatible blood. Okay, so that's one thing that's really handy so that you know. So the allergies tab is something that I want to clarify. That's really important to take a look at because antibodies come and go. And if somebody has a history of an anti-Duffy X, but for some reason we're not seeing it now because it's dropped down below the limits of detection, then we might have a negative antibody screen and you might not see this. So that allergies tab is the truth to say, yes, this patient has a history of this antibody, even if it's not currently showing, and we're still going to honor it. The other thing is that the pre-op area gets email notifications now from the blood bank. And again, this is something manual that the blood bank techs do. And it's going to tell you your patient has an unexpected antibody, and the antibody is whatever, we're going to fill in the blank. And depending on how hard it is to find compatible blood for that patient, then the email is going to tell you how long it's going to take. And so if we say it might take more than 8 hours, that means it might take a day or two before we can get compatible blood in. You might want to think twice about doing a surgery where the patient needs to be transfused. Okay? It also is going to tell you that your patient is not eligible for a 30-day pre-op specimen. But if that specimen was drawn within 7 days of the surgery, we can still use it. So that's why I just wanted to make sure that you understood all of the language that we're using and to understand that we send out these notifications to help you understand how much of a problem these antibodies are and where you can find that information. Okay, that's all I have. Any questions? Yeah. It actually goes to the people in charge of the pre-op services. So like the nurses, charge nurse, people in pre-op area, and they will notify whoever is responsible for the patient then. Yeah?
One of our huge issues is actually the disconnect between the lab and the blood bank. So a real common scenario is that we're trying to get blood components for a patient who's actively bleeding, and we get a call from a pathology resident who's saying, well, you need to follow up with all the CBC and you need to follow up with a platelet count. Well, one has been pending for around an hour, and it doesn't seem like there's communication between those two services about the really slow turnaround time between our labs and the operating room and being able to transfuse components in an appropriate time frame. Do you guys have like reference timing for how quick a turnaround tech should be, or how quick a turnaround platelet count or CBC?
Okay, so the question is about the disconnect between how long it takes to get a lab value and the calls from the pathology residents. We actually do know that. But part of it is a matter of we can't tell how fast the patient is bleeding or what's going on in the operating room. So when we're calling in there, a lot of times it's to say, like, what's up? Is the patient bleeding a lot? Because, for example, if you took a cooler 15 minutes ago and now you're asking for a platelet when a platelet was delivered with that last cooler, it's a matter of, have you already given all of those red cells? Like, how bad is this? It's not a matter of saying, oh, well, your CBC should be done by now. We know that it takes a while for those platelet counts to come out. The other thing is that, for example, you talk about the tag. We can't see the tag. If you're doing a tag that you can see in the operating room, we can't see that. So even if you can tell us, it looks like I'm going to have a low MA, my K time is prolonged, things like that, when we can't see it, that's the sort of thing that would be helpful. So just remembering that, we're not in the room with you, and considering we're responsible for transfusions all over the hospital, it's hard for us to be in every room where they're transfusing, just to tell us that. And for example, on the blood bank side, again, the blood bank is not on Epic. Epic does not have a blood bank module. So we're on Haemonetics SafeTrace TX, and we interface over to Epic. And so a lot of times our people, whether it's the techs or the residents, we're working in SafeTrace. We're not working in Epic. And so sometimes you do have to tell us, well, the CBC is pending, because we'll only see the CBC results when they're resulted. It's hard for us to see that it's actually been sent. So sometimes it just helps for us to know that you've done that. And a lot of times what we say is like, oh, if you tell me a patient's bleeding a lot and, oh, by the way, you're going to be ordering another cooler really soon, then we'll often just say, okay, we'll give you the benefit of the doubt. You can have this one and we'll watch for that platelet to result. Because then they'll have to go out and go hunting for that result and see what's going on with it. So.
I'm not trying to be flippant, but what sort of training do pathology residents get?
A lot. As a matter of fact, it's the sort of thing, we teach them about massive transfusion situations of dilutional coagulopathy, a lot of things having to do with transfusion. And as a matter of fact, one thought that I have is we do have some surgery residents who do a pathology elective and they spend a week in the blood bank, and all of you would be welcome to do that too, so you can see what we see from our side when we're talking about all this and the type of training that they get.
The converse is also true. Any pathology residents ever want around the CTIC one sometimes this will result in about 3 or 4 phone calls while a patient massively bleeding. It really delays care.
It's something, I agree that it's something that it can delay care. And honestly, I think we'd be happy to round with you in CTICU. We actually round with the bone marrow transplant team, so that's something that we could consider to do on a more regular basis. Again, just to get that exposure. So I think the communication is something that definitely can be a two-way thing. But again, it's not something that we can see what's going on. And sometimes it can be really hard to get information about what's going on because you're saying, well, it's obvious in terms of what's happening here in front of me. So that, okay, you can stop what you're doing with whatever it was you were doing before, because whenever the residents get questions about this, it's a matter of, it's an interruption from what they were doing to say, okay, call and check on this and see if this is okay or what's going on and how much we need. One thing to understand is that we also have to manage our inventory, and we don't have endless platelets in-house. And sometimes it's a matter of, okay, we're expecting our next platelet shipment in a matter of 2 hours. So in the meantime, we have 4 platelets on the shelf. We want to know, okay, do you need this right now, or like kind of prioritize who's going to be getting those platelet units? So it's something that there's a lot more that goes into it than just saying, oh, you ordered it, then you must definitely need it. Because again, go back to that wastage, that we have a lot of things that are ordered and are returned to us because they decided that they didn't need it. There's another question up there.
Mary, so in order to improve the waste in the operating room, it would be really helpful to know what's the average usage of all the different products for different procedures. And I think the problem that comes is when you have some patient coming for straightforward hepatitis, for example, you never know what's the average actually of products used. And you see that the surgery intern ordered 4 units of blood, we go to the attending surgeon, and they're not expecting major blood loss. So I think the problem with Epic and ordering blood products for a surgical case is not having a reference. For someone that is not familiar with, the type of PDL that should be expected. If we could have some pop-up saying, well, for this procedure, we've had an average use of 2 pack cells, maybe we just need to order 2. But we don't have that mechanism of talking back and forth with you.
Okay, so the comment is about not knowing how much to order in these cases. What I can tell you is that there's this thing in blood banking called the Maximum Surgical Blood Order Schedule, or MS-BOSS, and we actually have one for this institution. And what this is something that we've gone back to the data for all of the cases that we've done here. It was like over a 2-year period for our actual cases, and we've looked at how much blood those cases have used and made recommendations to say, for example, maybe you only need to get a type and screen on this case, or maybe you should cross-match 4 units on this case. So we have all that information in the blood bank, and the problem is we don't know how to get it to you because we haven't been able to get it into Epic. So it's there. But
Work with specific surgeons or groups of anesthesiology and surgery teams.
we would love to, but we don't know who and we don't know how. That's something that we've been trying to get the word out for a while, and we haven't had people take us up on it. Okay, because it's something that, if we just post that, we'd be happy to do that. But part of it is that, for example, we've taken it to, shall we say, certain surgery groups, and they've been really resistant to that idea, that they're kind of in denial. That's like, oh, no, well, we can't just do a type and screen there. So that's part of it, is we've been trying to go to the surgeons, and they haven't been very cooperative. So, okay. Any other questions? Okay, thank you.